Greetings all. Today we are going to discuss pituitary tumors. My name is Tamer Elsherbiny. I'm an associate professor in endocrinology unit, internal medicine department, Alexandria University. And the presentation today is going to handle the pituitary tumors. So in the first, we have to identify how anterior pituitary cells differentiate. So anterior pituitary cells originate from a multipotential stem cell, as you can see. And for this cell to differentiate into different anterior pituitary cells, so this has to be coordinated by specific transcription factors that we are going to identify, the first of which is pituitary specific transcription factor 1, or short for PIT1. And this allows this multipotential stem cell to differentiate into this long list of anterior pituitary cells. And so for PIT1, it differentiates the multipotential stem cell into somatotroph stem cell, and then it differentiates into somatotrophs capable only of secreting growth hormone, lactotrophs capable only of secreting prolactin, somatomamotroph capable of producing both prolactin and growth hormone, thyrotrophs capable only of secreting TSH, and it may differentiate into a less multipotential cell called plurihormonal cells that can secrete prolactin, growth hormone, and TSH. The second transcription factors is the T-box transcription factor, short for TBET, and this identifies cells capable of differentiating into corticotrophs. With the presence of TBET, the multipotential stem cell differentiates into corticotrophs capable of secreting ACTH. And finally, the steroidogenic factor 1, short for SF1, is capable of differentiating this multipotential cell into gonadotrophs, which is capable of secreting both FSH and LH. Second, we have to identify the anatomy of the pituitary gland. So here you can see the pituitary, and actually this is how it looks on MRI. This is the stalk, and you can see here the origin of the stalk in the imaging. This is the optic chiasm, and you can see here the optic chiasm as well. Below the pituitary gland, you can see the sphenoidal air sinuses, and here you can see the sphenoidal air sinuses. And on both sides, you can see the cavernous venous sinuses, and inside which you would find the internal carotid. And so here and here, this is the expected site for the cavernous venous sinuses, and these two rings represent the internal carotid. So this is how a normal pituitary gland would look like in MRI. Then we go for the classification of pituitary tumors, which has many classifications. Starting with the first classification, which classifies the pituitary tumors according to its size, it can be classified into either microadenomas, which have the maximum diameter of less than 10 millimeters, macroadenomas, which have a maximum diameter ranging from 10 to 40 millimeters, and giant adenomas, which have the maximum diameter greater than 40 millimeters. So this is an example of a microadenoma, this is an example of a macroadenoma, and this is an example of giant adenoma. It can be classified according to the clinical presentation. So about 1/3 of pituitary tumors do not oversecrete any of the anterior pituitary hormones, and those are classified as non-functioning adenomas. This is about 1/3. Or it may be a functional adenoma where it oversecretes or overproduces one of the anterior pituitary hormones. In half of the patients, it is a prolactinoma. In 8% of the patients, it is acromegaly, and the least common syndrome associated with an excess of an anterior pituitary hormone is the Cushing disease in 3% of the patients. Another classification depends on the staining of the excised pituitary tumors. So after excision of the pituitary tumors, we stain the pituitary tumor cells using what we call immunohistochemistry, and this shows the presence or absence of secretory granules within the tumor cells. So actually this would give us another set of classification, because some tumors may express secretory granules for certain hormones, but without expressing an excess of such hormone, and so the clinical presentation would be different from the histological classification. So most of the tumors either exhibit null cells which means they do not exhibit any of the secretory granules for any of the anterior pituitary hormones, or it may be LH and FSH staining adenomas, followed by ACTH positive adenomas in 15% of the patients, growth hormone secreting adenomas in 15% of the patients, prolactin expressing tumors in 9% of the patients, mixed growth hormone and prolactin in 6% of the patients, and the least to be expressed are either TSH expressing secretory granules or plurihormonal. Again, one other classification is related to the biological behavior. Most of the anterior pituitary tumors are adenomas. A rarity is considered to be carcinomas, representing only 0.1% to 0.4%. The only way to identify a pituitary tumor to be a carcinoma is the presence or absence of craniospinal or systemic metastasis. Adenomas, which are benign tumors, may be classified either as invasive or aggressive. And by invasive, we refer to adenomas that invade either the sphenoidal air sinus or the cavernous venous sinus, which occurs in up to 40% of the pituitary adenomas. Definitely, there is an increased likelihood of regrowth or recurrence after surgical intervention. And for an adenoma to be classified as aggressive, which only represents 2% of macroadenomas, first it has to be invasive and it has to be associated with rapid tumor growth rate. And rapid tumor growth rate is defined as 20% or more increase in the longest tumor diameter within a matter of 6 to 12 months. And then we have the surgical classification, which is actually related to the risk of having regrowth or recurrence of the tumor and the risk of having to add adjuvant therapies. And we have an old classification known as Hardy classification, which classifies small intracellular symmetrical pituitary tumors into non-invasive and those causing bone destruction into invasive. And you can see this classification in these pictures, with grade 0, 1, and 2 are classified as non-invasive, and those who invade the bone are classified as invasive. A more commonly used surgical classification is known as NOSP classification. And actually, the NOSP classification depends on the relation of the tumor to the internal carotid. So this is the internal carotid. If the tumor is limited to the internal carotid line, this is non-invasive, or it may be related to the intermediate carotid line or the lateral carotid line, and all these grades are considered to be non-invasive. If the tumor exceeds the lateral carotid line, this is considered to be invasive, and then you either have an invasion from superior to the internal carotid or inferior to the internal carotid or completely encasing the internal carotid. All of these are considered to be invasive. The last classification is the pathological classification. In 2017, the WHO replaced the term of pituitary adenomas into pituitary neuroendocrine tumors, and this classification depends on the expression of pituitary transcription factors, the ones that I have shown you in the first slide. And so the expression of PIT1 leads to differentiation of either mammosomatotrophs or somatotrophs or lactotrophs or thyrotrophs. The TBET expression leads to the differentiation of corticotrophs, or the steroidogenic factor 1 leads to differentiation of gonadotrophs. And so according to the expression of different transcription factors, we get a specific type of tumors. So PIT1 is essential for adenomas producing growth hormone. PIT1 is also essential for adenomas producing prolactin. PIT1 is also essential for adenomas expressing TSH. TBET is essential for adenomas producing ACTH. SF1 is essential for adenomas producing FSH and LH. Plurihormonal adenomas would express multiple factors, the most important of which would be PET1. And finally, hormone-negative adenomas are not expected to express any of these factors. So we have started with the classification of pituitary tumors, and then we are going to deal with two specific types of pituitary tumors. The first would be the prolactinomas, and the second would be the growth hormone secreting adenomas. So prolactinomas are benign prolactin secreting adenomas. They represent, as I have shown you before, about half of all pituitary adenomas in both males and females. The sex distribution differs according to the age. So for premenopausal women, actually females are more affected with a ratio of 5:1 and up to 10:1. However, after menopause, both males and females are equally affected. With the prolactinomas are micro, macro, or giant. So macroprolactinomas are the most frequent type. They rarely grow into macroprolactinomas. For macroprolactinomas, they are more common in males with a 4:1 ratio, and they are less common in females with a 1:8 ratio compared to microprolactinomas, while giant prolactinomas are only present in 4% or less of the patients. The clinical presentation in women differs according to the age. So in the reproductive age, they always or usually complain of oligo or amenorrhea or short luteal phase, which may present with short frequent cycles, infertility, and galactorrhea, which is present in almost 90% of the patients. While if she is a postmenopausal female, usually the presentation would be due to a mass effect. While for males, half of the males affected would present with signs or symptoms related to tumor mass, the most frequent of which would be visual impairment followed by headache, while the other half would complain of symptoms related to hypogonadism like loss of libido, erectile dysfunction, and infertility. Actually, causes of hyperprolactinemia are not merely prolactinomas. So you have to remember that we have a number of physiological causes like pregnancy and stress. We have the pharmacological causes, which actually represents up to 45% of all cases, including dopamine receptor blockers, antihypertensives, antidepressants, and antipsychotics, H2 blockers. You have also to remember that we have non-tumoral or non-pituitary disorders, including hypothyroidism, renal impairment, or liver impairment. We have even some cases of hyperprolactinemia with no identifiable cause, which is called idiopathic hyperprolactinemia, which may represent up to 15% of the cases. And for pathological causes, you have to remember that prolactinomas are the most common ones. So actually, the most common cause of hyperprolactinemia, the most common pathological cause is prolactinomas. And in general, the pituitary adenoma size is related to the level of prolactin. And so it is customary to identify pituitary tumors when the prolactin levels are greater than 200 or 250 nanograms per ml. This almost always correlates to the presence of a macroprolactinoma. You have to remember that stress may cause an elevation of prolactin level, and usually this would be in less than 4 times the upper limit of normal. 4 times the upper limit of normal. So as long as serum prolactin level is less than 5 times the upper limit of normal, you should suspect that this may be stress related. So stress may come actually from venipuncture. So if you suspect that this is stress related hyperprolactinemia, you have to go for this type of prolactin sampling. We call it cannulated prolactin sampling. Is recommended if an influence of stress is suspected. You have to exclude non-tumoral causes. One of the most important non-tumoral causes that has to be excluded in all the patients would be pregnancy. You have to exclude medications, which I have told you that it may represent up to 45% of all cases of hyperprolactinemia. You have to exclude primary hypothyroidism, renal insufficiency, and liver failure. So when to ask for prolactin in a patient who presents with what complaint? Any patient presenting with a cellular mass on imaging should be screened for the presence or absence of hyperprolactinemia. Any patient presenting with galactorrhea, of course, except for pregnancy and lactation. A patient presenting with loss of libido or infertility. A female presenting with new onset menstrual irregularities or amenorrhea. And finally, a male presenting with erectile dysfunction or a hypogonadotrophic hypogonadism in biochemical assay. You have to screen for hypopituitarism if you have diagnosed the patient with prolactinoma. because macroprolactinomas, and less frequently the microprolactinomas, may cause growth hormone deficiency, TSH deficiency, and ACTH deficiencies. So all patients have to be evaluated clinically and biochemically for the presence or absence of a deficiency in these hormones, and this has to be done for all macroadenomas and for microadenomas ranging in size from 6 to 9 millimeters. In all patients diagnosed with a prolactinoma, you have to screen for growth hormone excess, because some patients may present with a prolactinoma that is actually a part of a mixed tumor, which may be associated with a mixed hypersecretion of growth hormone and prolactin. The imaging of choice for a prolactinoma would be an MRI cella. It has to be dynamic, GAD enhanced. So the MRI should be performed in a patient with confirmed hyperprolactinemia if non-tumoral causes has been excluded. If you have started medical treatment for a patient with a prolactinoma to assess the response to medical treatment, and if a patient with prolactinoma was subjected to surgery, so to follow up the results of the surgery. If you have started dopamine agonist as medical treatment for a prolactinoma, so you have to follow up with an MRI for macroprolactinomas within 3 to 6 months, and for a microprolactinoma after 1 year of start of medical treatment. If you classify your patient as treatment responsive, no imaging is indicated beyond the first year of medical treatment. However, you have to perform an annual imaging for the first 3 years in 2 categories of patient: if the patient is classified as partially responsive, or if the patient is suffering from a macroprolactinoma that is close to the optic chiasm. Again, if you have diagnosed the patient with prolactinoma, you have to check for the presence or absence of bone disease, because hyperprolactinemia is associated with a hypogonadotrophic hypogonadism. This increases the risk of osteoporosis, which may actually increase the risk of fracture. So you have to have a baseline DEXA in order to assess the bone mineral density if the patient is suspected to have a long-standing hypogonadotrophic hypogonadism, and by long-standing means it gave history of more than 6 months, or if the patient has other risk factors for osteoporosis, like in menopausal women. Also, if you diagnose a patient with a prolactinoma, you have to assess for other complications like hypogonadism. After start of treatment, some patients may recover from hypogonadism. So you have to evaluate if the patient have restored gonadal function. This should be performed at least 6 months after normalization of prolactin. This should be expected in 60% of male patients, while actually this is even more frequent in women. If the patient is complaining of hypogonadism as part of ban-hypopit, so the chances of recovery is low. So dopamine agonists represent the mainstay of treating a patient with a prolactinoma. So dopamine agonist is highly effective in lowering or normalizing the level of prolactin and reducing the adenoma size. Actually, cabergoline is the preferred dopamine agonist due to its long half-life, high efficacy, and good overall safety and tolerability. So the use of cabergoline as first-line treatment is recommended regardless of the tumor size and regardless of the severity of neurological and ophthalmologic damage. Actually, dopamine agonist can normalize serum prolactin in almost 90% of microprolactinomas and in up to 80% of macroprolactinomas. Tumor shrinkage and not tumor disappearance can be achieved in more than 90% of macroprolactinomas. But you have to highlight to your patient that the need for dopamine agonist is actually for long term, and there are limited chances that the patient may achieve permanent cure. And by cure means that the patient would achieve a normal prolactin without the dopamine agonist treatment. So this should be highlighted in the patient discussion. So a meta-analysis showed that long-term disease remission, that's to say long-lasting normal prolactin without dopamine agonist, can only be achieved in 30% of microprolactinomas and in 28% of macroprolactinomas, which means that almost 3 in 10 patients can achieve long-lasting remission without dopamine agonists. So if you are dealing with a microprolactinoma, the treatment should be lifelong in male patients, and in females, it can be safely stopped after menopause. In macroprolactinomas, you have to identify that the treatment should be lifelong, and any attempt to withdraw the treatment should require long follow-up. About the adverse effects of dopamine agonist, a number of few and usually tolerated adverse effects have been reported with dopamine agonist. The main dopamine agonists include the gastrointestinal symptoms like gastric discomfort, nausea and vomiting, plus dizziness and fatigue. Usually the adverse effects improve with time, and you can improve the tolerability by administering a dopamine agonist before bedtime or with food, and starting with a low dose and slightly or slowly escalating the dose. You have to remember that some patients may complain from impulse control disorders while using the dopamine agonist. This occurs rarely, and by impulse control disorders, we are referring to compulsive buying, gambling, or aggression, changes in the mood in the form of depression or mania, or maybe hypersexuality in men. If this impulse control disorders is present, dopamine agonist has to be either down titrated or discontinued. Also, if the patient is going to use a large dose of cabergoline, which refers to more than 2 milligrams per week, this patient is at risk of developing cardiac valve fibrosis, or what we call cardiac valvulopathy. So, if your patient is expected to require such large dose of cabergoline, you have to acquire a baseline echo evaluation before starting the cabergoline, and then to repeat it every 2 to 3 years. However, if the patient is using less than 2 milligrams per week, you may perform echocardiography after 5 to 6 years of starting your patient a dopamine agonist. So for treatment withdrawal, as I have shown you, only 30% are expected to achieve long-lasting remission, and in other estimations, only 1/5 of patients can remain in remission after discontinuing cabergoline. So dose reduction or treatment withdrawal may be considered. You have to consider a number of factors before trying to stop or withdraw your treatment, including if the patient is controlled on low maintenance dose, the patient has achieved treatment duration of more than 2 years, and you have achieved substantial adenoma size regression or reduction on imaging. The chances of permanent resolution increases at menopause and after pregnancy, and so you have to remember these two golden times if you wish to withdraw the treatment from your patient. If you have successfully withdrawn the cabergoline, you should have lifelong evaluation of serum prolactin every 3 months in the first year, and then annually, and you should inform your patient about the symptoms of recurrence. That is why there is a recommendation that dopamine agonists should be withdrawn in females after the menopause, and again, another set of favorable factors which may increase the long-lasting remission chances, including complete disappearance of tumor mass, or at least a 50% reduction in tumor size, persistently low normal prolactin. After down titration of the dose, you have to carefully, quarterly, annually follow up your patients. So when to go for surgery in a patient with a prolactinoma? So surgery is recommended if there is rapidly progressive vision loss due to a cellular mass or due to apoplexy. Surgery is an option if the patient is tolerant or resistant to dopamine agonist, and surgical reveal should be performed if the patient presents with spontaneous CSF rhinorrhea. So surgery should be offered with an expert pituitary surgeon, because actually this is the main determinant of the outcomes of surgery in a pituitary tumor. So you have to offer surgery if there is no quick improvement of severe neuro-ophthalmologic damage with dopamine agonist, and by rapid we are talking about 2 weeks if the patient is resistant or intolerant to dopamine agonist, or if the patient has shown initial response to dopamine agonist and then escaped the dopamine agonist effect. Radiation therapy is the third-line treatment in a patient with prolactinoma. So radiation therapy should be reserved to patients who show bore mass shrinkage to dopamine agonist and non-resectable residual after surgery, or there is contraindication for surgery. If you are going to perform radiation therapy, stereotactic radiotherapy like gamma knife is preferred over conventional. One of the main limitations of radiation therapy is that the response to radiotherapy can take several years. Again, radiotherapy is non-selective, and so it can lead to hypopituitarism. So it can lead to hypopituitarism, optic neuropathy, cranial nerve palsy, or second brain tumors. So if radiation therapy is selected, you have to know that there is a contraindication for the stereotactic surgery. So if the tumor is too close to optic pathways or diffusely infiltrating the surrounding anatomical structures, you can go for stereotactic surgery. One last addition to this option of treatment is that you have to perform prolonged yearly, actually a lifelong yearly follow-up to evaluate the efficacy and safety of radiotherapy. The second syndrome of anterior pituitary hypersecretion is going to be acromegaly. Actually, by acromegaly, we are referring to enlargement of the extremities. And so enlargement corresponds to the term of megaly, and the extremities corresponds to the part where the acral parts. Usually, this is a slowly progressive disease resulting from increased secretion of growth hormone, which consequently leads to the increased release of IGF-1. We have two clinical syndromes of growth hormone excess. The first is gigantism, which occurs when growth hormone excess occurs before epiphyseal closure, and the second growth hormone clinical syndrome is acromegaly, which occurs when growth hormone excess occurs after epiphyseal closure. Causes of acromegaly: in more than 99% of the cases, it is a growth hormone secreting pituitary tumor, and in less than 1% of the patients, it is due to primary pituitary hyperplasia or ectopic secretion of growth hormone itself or ectopic secretion of growth hormone releasing hormone. For growth hormone secreting adenomas, it can be pure, which means only secreting growth hormone, or it can be part of more than one hormone being secreted from the tumors, including mammosomatotrope adenoma, mixed growth hormone and prolactin secreting adenomas, mature or immature plurihormonal adenomas, or acidophil stem cell adenomas. And you can see here a representative example of plurihormonal PIT1 expressing positive adenomas, or acidophil stem cell adenoma expressing prolactin growth hormone. Growth hormone secreting adenomas are present in more than 99% of patients with acromegaly, with more than 70% of those are macroadenomas at the time of presentation. Other rarer causes present in less than 1% of the patients are the primary somatotrope hyperplasia, which occurs in rare genetic syndromes. If you have no adenoma, then you should suspect maybe that this patient is caused by an ectopic secretion of growth hormone. As I told you, the ectopic disease represents less than 1%. It may be due to ectopic growth hormone production, and in such cases, you should expect a small pituitary gland or ectopic GHRH secretion, which leads to secondary pituitary hyperplasia, which is actually difficult to differentiate from a pituitary tumor in the imaging. How common is acromegaly? For the incidence, studies published in the 80s and 90s, the annual incidence was about 3 to 4 cases per 1 million individuals per year. In more recent studies, it has risen up to 10 cases per 1 million population per year. For the actual prevalence, which refers to the number of existing cases rather than new cases, before the year of 2000, the global prevalence was less than 7 cases per 100,000 individuals. In the past 5 years, it has reached up to more than 13 cases per 100,000 individuals. For age, a median age at diagnosis is 40 to 50 years of age, and there is no difference for acromegaly between males and females. However, pituitary gigantism is a male predominant disorder. For the clinical presentation, the main clinical presentation is in the form of acral dysmorphia and facial dysmorphia. And by acral dysmorphia, we are referring to wide hands and feet, broad stubby fingers and toes, thick and soft tissues. For facial dysmorphia, we are referring to rectangular face, enlarged wide nose, prominent cheekbones, a bulging forehead, thickened lips, and prognathism. And you can see here the slowly progressive change in the face from the 70s and up to 2011. We are talking about a time lapse more than 30 years of age for this patient to reach from this look to this look. So one marked remark about this disease is a diagnostic delay. So the diagnostic delay before 1990 was more than 20 years. In the 90s, it has decreased to 10 years diagnostic delay, and in the thousands, it has decreased to only 5 years diagnostic delay. Other non-specific symptoms, and by non-specific symptoms, we refer to symptoms which may exist with acromegaly and may exist with other diseases other than acromegaly. This includes the headache, which is the second most common initial complaint to present in a patient with acromegaly, asthenia, hyperhidrosis, paresthesia in the extremities, most probably with underlying carpal tunnel syndrome, arthralgia, which may affect up to 70% of the patients, diabetes and impaired glucose tolerance, which may affect up to half of the patients, hypertension again, up to half of the patients, obstructive sleep apnea affecting up to 80% of the patients, cardiomyopathy, which is characterized in acromegaly by not involving the coronary, colonic polyps in up to 45% of the patients, and most of which are adenomas, not tumors. And finally, goiter is one of the non-specific comorbidities to be associated with acromegaly. Because most of the growth hormone pituitary adenomas at the time of presentation are macroadenomas, so hypopituitarism is a common presentation, with hypogonadism the most common part or the most common component of hypopituitarism at the time of presentation, affecting up to 50% of the patients. In such patients, infertility may be caused by hypopituitarism, caused by a mass effect, may be caused by hyperprolactinemia, or may be caused by both. We have to remember that growth hormone and IGF can inhibit GnRH hormone, and they can induce polycystic ovary syndrome in female patients. Other pituitary deficiencies are actually rare. So here we can find a long list of specific and non-specific presentations associated with a patient with acromegaly, including cardiovascular presentations, the most important of which would be hypertension and cardiomyopathy, respiratory presentations in the form of obstructive or central sleep apnea, musculoskeletal presentation in the form of arthropathy and jaw malocclusion, metabolic and endocrine presentations, the most prominent of which would be the hyperprolactinemia and diabetes, neurological presentations including nerve entrapment syndromes, neoplastic presentations because patients with acromegaly is at higher risk of cancers including colon, breast, thyroid, and renal cancers, the mass effect which may cause the headache, the hypopituitarism, and cranial nerve pulses including the third, fourth, and sixth cranial nerves, and the impaired quality of life. About the differential diagnosis, other causes which may give a similar presentation to acromegaly include pachydermal periostosis, also known as primary hypertrophic osteoarthropathy, and some patients with severe insulin resistance may have some acromegalic features. However, they have normal growth hormone and IGF-1s. Also included in the differential diagnosis that some patients present with typical signs and symptoms of acromegaly with a normal IGF-1 and normal growth hormone, probably due to spontaneous resolution. So we are talking about a disease which may spontaneously remit, and this can occur by spontaneous necrosis or spontaneous apoplexy. What we know about apoplexy is that it is usually associated with a sudden and very severe headache, which is sometimes associated with oculomotor nerve palsy. However, sometimes spontaneous apoplexy leading to cure of the adenoma may be clinically silent. And in such patients, the deformation that affects the sella turcica does not resolve. And so you would find a patient with typical signs and symptoms of acromegaly, with a normal IGF-1 and growth hormone, with a deformation of the sella underlying a previously existent growth hormone secreting adenoma. How to diagnose? Generally, the diagnosis relies on elevated IGF-1 concentrations and absence of growth hormone suppression after oral glucose tolerance test. So the IGF-1 is produced by the liver under control or under stimulatory control of growth hormone, has a half-life of 15 hours, which is unlike the growth hormone, which is secreted in pulsatile secretion that I'm going to show you shortly, with a shorter half-life of only 15 minutes. So we are comparing 15 hours to 15 minutes. So finding a normal age and sex-specific IGF-1s usually excludes active acromegaly. A very high IGF-1 associated with typical signs and symptoms of acromegaly usually indicates the presence of acromegaly. However, a mild elevation of IGF-1 you have to confirm with growth hormone suppression after oral glucose tolerance test. We have to remember that we have false highs and false lows for IGF-1. The false highs associated with pregnancy and puberty, and the false lows are associated with uncontrolled diabetes and renal failure. Then we go for the growth hormones. So usually growth hormone is secreted in a pulsatile fashion, like you can see here. So these are called pulses. Okay, so we get more pulses, more frequent pulses with a higher amplitude during sleep, and we get fewer pulses with a lower amplitude during the day. And as you can see, during the pulses you can get up to 30 nanograms per ml. So actually these pulses are under stimulatory and inhibitory control of two factors. Somatostatin, which is mainly inhibitory, this is the predominant during the day, and they cause a very low or undetectable growth hormones. And we have the stimulatory GHRH tone, which is usually the predominant during sleep, and it can produce these pulsatile. So growth hormone levels range from undetectable to a peak level of 30 micrograms per liter or nanograms per ml, and so you can't rely on a random growth hormone sample for the diagnosis of acromegaly. So you have to go for oral glucose tolerance test. What does glucose load lead to? It leads to inhibition of GHRH, the stimulatory one, or an induction of somatostatin, which is the inhibitory one, or actually it may achieve both, and so it is expected to suppress the growth hormone. About the diagnostic cutoff, a lack of suppression of growth hormone to below 1 microgram per liter or nanogram per ml following confirmed hyperglycemia during oral glucose tolerance test is diagnostic of growth hormone excess. If you are a good reader, if you read updated literature, you would identify some guidelines recommending the use of these cutoff limits, 0.4 and 0.1. And so should we use this one or this one? Actually, this relies on which assay that you are using. So for the older assays, those are not ultra sensitive. You should use the 1 nanogram per ml or 1 microgram per liter cutoff limit, which is actually available in our country. Only if you have these modern assays, the ultra sensitive assays, that you can use these cutoff limits. Some patients may actually show paradoxical growth hormone response, and paradoxical growth hormone response. So instead of having a suppression or a mild suppression of growth hormone with hyperglycemia, you would get a stimulatory effect with hyperglycemia. This occurs in about 25 to 30% of the patients, and this can be explained by the release of GIB from duodenal key cells, which act on the adenoma cells. They have observed that patients who show this paradoxical response, they are associated with a smaller adenomas and greater response to medical treatment. About the imaging, you should expect one of 3 or 4 imaging phenotypes, starting with macroadenomas. So the macroadenomas represent more than 70% of growth hormone secreting adenomas. They are 10 millimeters in diameter or greater, and the lesion appears hyper intense after GAD injection, as you can see here. So the MRI allows you to assess the supracellular extension, the infracellular extension, and the lateral extension. You should also expect macroadenomas, and by macroadenomas we're referring to adenomas that is less than 10 millimeters in diameter. They are only found in 20% of the patients, and as you can see here, they show a hypointense lesion after GAD injection. Two other phenotypes, imaging phenotypes, that can be present in less than 1% of the patients. The first would be an empty cella. This may have occurred due to previous pituitary apoplexy that I have explained before, or after surgical treatment for a pituitary adenoma, or due to ectopic growth hormone secreting adenoma. Another rare presentation would include primary or secondary pituitary hyperplasia. The primary is one of the rare causes that I have told you about, and the secondary is always secondary to an ectopic GHRH secreting adenoma, and the primary or secondary pituitary hyperplasia would look like a diffuse enlargement, as you can see here, and then sometimes it may be challenging to differentiate the hyperplasia from a pituitary adenoma. For the treatment goals should be to normalize age and sex-specific IGF-1s and to reduce growth hormone concentrations to less than 1 nanogram per ml or 1 microgram per liter, if you are using the conventional assays, which is available in Egypt, or less than 0.4 nanogram per ml if you are using the ultrasensitive assays. The treatment modalities include surgical resection. This is the first line approach for patients. Or if the complete resection of the tumor is not available, then we may go for debulking surgery. Medical treatment should be the second line of treatment. Primary medical therapy may be resorted to if the patient are unlikely to achieve surgical cure. The last line of treatment would be radiotherapy. Actually, surgical outcomes is largely dependent on the size of the adenomas. So you can achieve remission using surgery in up to 90% of patients with microadenomas. But you can only achieve surgical remission in up to 60% of the patients if you are dealing with a macroadenoma. Surgical experience remains the main determinant of success. Endoscopic techniques is slightly superior to microscopic techniques. Complications of surgery include CSF leak, hypopituitarism, and transient diabetes insipidus. For medical treatment, the first-line medical treatment mainly relies on first-generation somatostatin receptor ligands or somatostatin analogs. The commonly used first-generation somatostatin analogs include octreotide long-acting release, short for octreotide large, or lanreotide, short for LAN. They are equivalent, and they can produce biochemical control in up to 55% of the patients and tumor shrinkage in up to 80% of the patients. Actually, you can predict the response to first-generation somatostatin analogs by looking at the signal intensity in MRIs. So if you detect hypointensity in MRIs, this leads to a greater reduction in growth hormone and IGF-1s and greater tumor shrinkage in the first 6 months of treatment. And so if you can see here, this is a hyperintense pituitary adenoma, and this is a hypointense pituitary adenoma, and definitely this would produce a better response to first-generation somatostatin analogs. Second-line medical treatment include dopamine agonist, and dopamine agonist, specifically cabergoline, can be used as first-line medical treatment in patients with a mildly elevated growth hormone and IGF-1s, or in combination with first-generation somatostatin analogs who are initially resistant to the first-line treatment. Bigvizumab, which is a growth hormone receptor antagonist, is indicated after failure of surgery or resistance to first-line somatostatin receptor agonist. It can be used either as monotherapy or in combination with somatostatin analogs. The second generation somatostatin analog, pasireotide, a very expensive medication, injectable medication, not available in Egypt. However, it is indicated if surgery is unsuccessful or treatment with first generation somatostatin analogs is not effective. As usual, radiotherapy is the last line of treatment. It is only used if there is unsuccessful surgery and if medical therapy as well is unavailable, unsuccessful, or untolerated. If you are going to use radiotherapy, stereotactic radiotherapy is better than conventional radiation therapy. In the last slide, this is a prognostic tip. They found that adenomas secreting both growth hormone and prolactin levels were less likely to achieve surgical remission and more likely to require adjuvant therapy compared to patients who present with pure growth hormone secreting adenomas. This was our lecture, pituitary adenomas. We have dealt with classification of pituitary adenomas. We also have dealt with two anterior pituitary hormone excess syndromes. This is the prolactinoma, acromegaly, and gigantism. I hope this was helpful, and inshallah, I hope to see you inshallah bi'Iznillah in clinical teaching. Thank you all.